Warm greetings. I'm Dr. Nipun Raghuvanshi, consultant neuroradiologist from Annapurna Neuro Hospital, Kathmandu. So today I'd like to talk about the epilepsy protocol in MRI in intractable seizures. So in many patients with epilepsy, the drugs given for the same are not able to control the seizures. So using the MRI protocol helps us to detect an epileptogenic lesion in about 80% of the cases. And resection of these lesions can lead to seizure freedom in many patients. So I cannot overemphasize the importance of an epilepsy protocol in these kinds of patients. One of the most important would be the T1 isotropic 3D sequence that is used nowadays, and also a FLAIR coronal image that is included in the protocol. All the other sequences that is done for a normal head MRI are also included. So the most important sequence that we use is the FLAIR coronal oblique sequence. So we take a coronal section of the brain, which is slightly oblique and is perpendicular to that of the hippocampal regions, and it is of 2 mm cuts, so that the bilateral hippocampal regions are well defined, and we can take a good look at these areas. So the purpose of this is to look for cortical or subcortical hyperintensities, mainly in case of mesial temporal sclerosis. The other important sequence that is added in epilepsy protocol is the T1 3D isotropic coronal oblique. The purpose is this is for visualization of the brain anatomy and morphology. And it is also important to measure the cortical thickness and appreciate the gray white matter differentiation, as it is of very thin cut. It is also used to visualize the unusual location of gray matter, as in heterotopias. So just a general overview of epilepsy. In general population, the first ever seizure is seen in about 4% of the population. Epilepsy is seen in about 1% of the population, and epilepsy, which is uncontrollable, is seen in less than 1% of the population. So of these, about 80% of these have epileptogenic focus on dedicated MRI. The causes of intractable epilepsy are many, and one of the most important one is mesial temporal sclerosis. There are developmental abnormalities such as focal cortical dysplasia, heterotopia, polymicrogyria, hemimegalencephaly, and schizencephaly. There are also tumors that cause epilepsy. Most commonly seen are gliomas, DNET, pleomorphic xanthostrocytoma, and hypothalamic hamartomas. Gliosis, that is scars, are also one of the common causes of epilepsy. Other causes such as Rasmussen's encephalitis and cavernomas could also cause this condition. Neurocutaneous syndromes such as Sturge-Weber syndrome and tuberous sclerosis are one of the etiologies. So this is a diagrammatic representation of the foci that would cause epilepsy, as I would come into detail about the MRI features of these conditions. So the most common site for epileptogenic foci are the temporal lobe, that is seen in about 60% of cases, frontal lobe in 20%, parietal lobe in 10%, and occipital lobe in 5%. So who needs imaging? Not every person with epilepsy needs imaging. So people who have focal neurological deficits or asymmetry are the main people who need imaging. Neurocutaneous syndromes, developmental regressions, simple partial seizures, refractory complex partial seizures, that is at least one seizure per month, not responding to anticonvulsant therapy, and children with myoclonic seizures and infantile spasm that present in the first year of life. So talking about the specific conditions and the MRI findings that cause epilepsy are, the most important one is the mesial temporal sclerosis that we encounter almost 3 to 4 times a week in our institution. So here what we see is that there is hyperintense signal within the right hippocampal area in T1, in T2 as well as in FLAIR, that is pointed down by the red arrow. Same thing in the left side, there is T2 and FLAIR hyperintensity in the left hippocampal area, along with a condition known as focal cortical dysplasia that is represented by a hyperintense signal in the gray-white matter junction. As you can see here in the left temporal lobe, that is denoted by the blue arrow here. So in mesial temporal sclerosis, there could also be, there is also volume loss of the hippocampal regions that could be represented by a prominent temporal horn, as well as loss of parenchymal volume, as you can see here, that is represented by the yellow arrow. So MTS is treatable surgically nowadays by a procedure known as amygdalohippocampectomy. As you can see here, this is a post-operative image of MRI image of the condition in which there is removal of the amygdala and the hippocampus, which is represented by a CSF-filled cavity post-operative change. So there are other conditions in which hippocampal hyperintensities are seen in T2 and FLAIR sequences, but without volume loss. So the differential diagnosis of these would be a case of status epilepticus, low-grade tumors such as astrocytomas and DNET, as well as encephalitis could mimic MTS. So this is a condition in which the patient just had seizures, that is status epilepticus, and we can see that the FLAIR is showing a high signal in the left hippocampal area, along with some diffusion restriction. So we should not be confused with this condition with MTS, and clinical history is very important. This is a tumor that is mimicking hyperintensity in the right hippocampal area. And of course, here we see that there's a bubbly appearance, and it is not very similar to what we usually see in MTS. Focal cortical dysplasias are another important, very important etiologies for epilepsy. That occurs in 5 to 25% of focal epilepsy. So the MRI finding here would be just subtle cortical and subcortical high signal intensity, often located at the bottom of the deep sulcus. There is focal cortical thickening and also slight loss of gray-white matter differentiation. There's a sign known as the transmantle sign, which I'll come to in the following slides. So this again is a combination of MTS in which there is hyperintense signal in the left hippocampus, and also cortical and subcortical hyperintensity with loss of differentiation. So this is a typical focal cortical dysplasia that is seen in the books and also in most of our clinical cases. So here there is thickening and hyperintensity of the cortex of the left superior frontal gyrus. In FLAIR as well as in T2, there is high signal of the subcortical white matter with prominence of the cortex. So talking about the transmantle sign in case of focal cortical dysplasia, it is hyperintensity that is extending from the subcortical area to the margin of the ventricles, as you can see. So that is the hyperintensity that is involving the cortex with a thin hyperintense line that is moving towards the ventricles. So this is all because of arrested neuronal migration. Cavernomas are another important etiology for epilepsy. In cavernomas, it is a typical popcorn-like appearance of the lesion, and there is surrounding as well as intralesional blooming artifacts seen in susceptibility-weighted imaging. So, ganglioglioma is a tumor that is commonly associated with epilepsy. So ganglioglioma, they present as a cystic lesion with enhancing mural nodules, and or they can be, of course, entirely solid in some cases, but the presence of perilesional edema is usually absent in these cases, and the tumor could calcify in about 50% of cases. Dinette, as I was talking about earlier, is a tumor that has a typical bubbly appearance, usually present at the cortical region. They cause a swollen gyrus, and they may be wedge-shaped, and they point towards the ventricles. Usually there is little or no enhancement of these lesions, and also they could be associated with FCDs. In our setting, in our Asian setting, at least in India, Nepal, Bangladesh, Pakistan, granulomas are very common. May it be granulomas due to NCC or tuberculosis. So these granulomas, when they calcify, they usually have low signal in case of susceptibility weighted imaging, as you can see here, and a mixed signal or a usually low signal in case of filtered phase sequence. So that is how you can say that it is a calcified granuloma, may it be due to any condition. So hemimegalencephaly is another condition, but it is not very common. Here you can see an enlarged unilateral cerebral hemisphere with ipsilateral ventriculomegaly. Tuberous sclerosis is another cause. So in tuberous sclerosis, we can see that the entity is composed of cortical hamartomas, the subependymal tumors, as is represented in these MRI pictures. Subependymal giant cell tumor is a tumor that is associated with this condition within the ventricles, and white matter abnormalities can also be seen. Sturge-Weber syndrome, it is a condition in which there is a typical cortical tram tract calcification of the affected area, which is usually seen in very well appreciated in case of plain CT scans. While doing a contrast study of MRI, there are a leptomeningeal enhancement, and also atrophy occurs in these cases, mainly in the posterior region. So here there is cortical leptomeningeal enhancement, tram tract appearance in case of CT, and also some amount of volume loss posteriorly. Polymicrogyria is another condition. As accordance to the name, there are numerous small gyri. It has a high predilection for the region of the sylvian fissures, and there's atrophy mainly in the posterior aspect. So as you can see here, there is an asymmetry between the two cerebral hemispheres due to small multiple gyri in the left side that is represented by these red and blue arrows. Gray matter heterotopias are another condition. As you can see in these, there are these nodular foci of gray matter intensity on all sequences, and they do not strictly enhance. Schizencephaly is another condition in which there is a CSF filled cleft that is extending from the cortex to the ventricular surface, and is lined by gray matter, and is one of the most I wouldn't say very common, but frequently seen pathologies. that cause epilepsy. So I could not overemphasize the importance of an epilepsy protocol for the diagnosis of epilepsy. So it is a group of MRI sequences that is put together to improve the sensitivity and specificity in identifying possible structural abnormalities that underlie seizure disorders. MRI is the modality of choice for epilepsy investigations, especially in 3 Tesla MRI. Thank you.